I'll just go. So this is intended to be interactive from all people in the room, including the panel members, as we go along. So there's lots of points I want you to tell me what you're going to do. It's about Mr. P. And it's a longish story of Mr. P. He's been known for a long time by Prince Charles, where I've known him from. But he comes to you as the GP and says, I've just moved up from Sydney. Can I get some repeat scripts, please? And he brings a letter from his cardiologist, which notes the following. He's got a background of ischemic cardiomyopathy, had bypass surgery 10 years ago now. His ejection fraction, it was 35%. Had an ICD implanted in 2002 for primary prevention and a generator change in 2012. He's got type 2 diabetes mellitus, which is pretty well controlled as at this point in the year. Hypertension, osteoarthritis, obesity with a BMI of 36. He weighs 116 kilograms. He's got a few pills there, which I'm sure you'll enjoy typing into your computer right away. And you can see most kinds of things are covered there, or they could argue what's going on with some of those doses. So he says, yes, I need scripts for everything, please. Oh, and by the way, I had a blackout last night. I was folding up my laundry. So I'll throw it to the audience now, and fellow panel members, what are we going to do with him? That's early. Bring your response. Asking more is always a good start, isn't it? So yes, what kind of things do we want to ask him? Yes, it's a very good start. What he's saying, had he just stood up, the other classic one that happens all the time with these over-diaries, heart failure patients, he's moved up from Sydney to a hot Queensland. It's clearly been into summer, so we're talking the end of 2013. Is it simple as that? What else do you wonder? Yep, always helpful, because it could it be non-cardiac seizure, like a seizure type of phenomenon. What other preceding symptoms you might wonder about? Chest pain, palpitations, are the classic ones to wonder about, aren't there? Sorry? Twitches and seizures afterwards, which are always a difficult one though, because everyone gets that little few flickers of twitching after they black out for a few seconds, which almost whatever the etiology is, and it's trying to distinguish that from epilepsy can be a more challenging thing. And of course with that goes continence, which is fairly sensitive, or specific rather, for epilepsy, but not perfect again. I guess having established that he has no real recollection of what happened other than he was folding the laundry, and then he woke up lying on the laundry, what do you do with him? He now says the important thing is this is about a week ago, so it wasn't like it's just happened today. No, he hasn't had this happen to him before, no. Yeah, okay. Whoops, I got that. So he's got a civilised blood pressure, no postural drop at the time. Blood pressure is 125 on 84. No postural drop. Heart rate is about 70. Nothing much else to find. Check his sugar, good idea. He's not on anything that should drop. He's always got some glimepiride, isn't there? So he could get a bit of hypoglycemia from that, and insulin as well. Yep, fair thing to do. But I mean, this is now a week after the event, isn't it? His BSL, his HbA1c is 6.9%, so his BSL is reasonably controlled, but not over-controlled. And he's not hypoglycemic right now. Pardon? Get an ECG, it's good. Yes, I failed to put an ECG. His ECG shows sinus rhythm, a left axis, is otherwise pretty unremarkable. Pardon? There's a little secret here, though. He's got an ICD in already, doesn't he? So I think the first thing we need to do is get someone to look at that and see what it found, because that'll tell us an awful lot about his background there, and saves you an awful lot of work as well. And clearly, the man with a complicated history like this, he needs a cardiologist at least to follow up his ICD, if nothing else. So that's what happens next to him. And he gets that on his ICD. And I might even ask Dr. Stafford to comment on what he thinks of that, seeing as that's more his space.
So when you've got a patient with an ICD, it provides you a really reliable and excellent snapshot of what's happening if there's any arrhythmias. So these devices are set up that they will record and maintain for you the intracardiac electrograms from any arrhythmic events that occur. And it keeps a log, so it's got a written log to say there was VT at this time, and this is the rate, and this is how long it lasts. And then it has very often a stored electrogram to actually allow you to go back and confirm that in fact the device made the right diagnosis and that it was indeed VT and not say an SVT or AF or with rapid response or something else. So these devices are really an excellent thing to have in, and if you've got one, to help sort out this type of problem. I'm sort of looking on the diagonal, but clearly the patient, I think the upper one is...
I'll show you this.
Electrogram.
So it's got, sorry, top one's atrial, bottom one's ventricular.
Right. So,
and I've got another one to show you as well, just might help you more.
Maybe if I comment on... Okay, that's still on the same episode?
Yeah, same episode.
If you go back to the first one again, so what we've got here is in fact a bitachycardia. If you look at the top line, that's the atrial electrogram, and the patient's got very rapid ventricular rate. So those squares will be the 200 milliseconds or 0.02 seconds that we see on the standard ECG. And you can see that the atrium has a very rapid arrhythmia there. It also looks very disorganised and irregular, so almost certainly that's atrial fibrillation. But if you look at the bottom line, you can see a very rapid, the next line down is the ventricular electrogram, and it shows an even more rapid ventricular response, which is again what we call polymorphic. So it's not uniform from one beat to the next, it's changing, but it's extremely rapid. So this is either a very rapid polymorphic ventricular tachycardia or ventricular fibrillation, and often it just gets down to what the actual rate is. If it's over 300 beats a minute, we'd probably call it ventricular fibrillation. And then the one below that is the marker channel. So it tells you what the device is seeing. And if we go back to the first one again, you can see the device is saying that there's an rapid atrial rate there, and it gives you numbers, which is the cycle length in milliseconds, which means the interval between beats measured in milliseconds. And it confirms an atrial and a very rapid ventricular arrhythmia. 220 milliseconds is sort of just over 300 beats a minute. So very rapid ventricular arrhythmia in the setting of atrial fibrillation. Next slide then, Scott. And is this is still... is that after a shock or before, do we know?
That's before shock.
That's before shock. Because it's
and he gets shocked at the end of that.
Yeah, he reverts back from the atrial fibrillation to sinus rhythm. You can see that suddenly...
there was a shock between those two bits. Yeah,
I thought there might be, because what you sometimes see is that you get a shock and it not only reverts the ventricular arrhythmia, but it reverts the atrial arrhythmia. So he's reverted from atrial fibrillation to sinus rhythm, but his ventricular arrhythmia hasn't reverted with that first shock. The devices are often set up that they deliver a lower shock for the first shock and then a higher energy shock, the maximum output for the second shock, depending on the rate of the arrhythmia. One of the reasons for doing that is that the defibrillator can charge up more quickly, and secondly, a lower energy shock may be perceived by the patient as less uncomfortable than a high energy shock. I have to say it really has to be very low energy before it's perceived any differently. So what we find is for most patients, a low energy shock and a high energy shock feel the same. It's a pretty uncomfortable thump in the chest if you're conscious when it happens. In this case, he wasn't, so he didn't feel either of these. But I would say that he got a lower energy shock, or it may have been maximum output shock, but it hasn't been successful in reverting the VF, but it has successfully reverted the AF. Not quite what we'd want there. And then because he's still standing in front of us now, I presume that there was another shock.
There was another shock.
Which was successful. So the device has told us, firstly, what the rhythm was at the time. It then shows us how it intervened, and then we can assess how effective that intervention was. And I think it also illustrates the case that Scott mentioned in the beginning, that this device was put in because as what we call a primary prevention device. And we can go into this in a little bit more detail afterwards, because I think it's an interesting point. But in fact, most likely he had never had a ventricular arrhythmia documented. But it was determined that he was in a high-risk group and high risk for developing either a cardiac arrest or a life-threatening ventricular arrhythmia, and he received the device as a prevention for dying suddenly if that event occurs. And here we are, several years down the track, and it's occurred. And this is the reason we use primary prevention devices, and it shows the effectiveness when you've got one of these in.
Do these devices feed back immediately so someone at the far end of a computer would know that this has happened and be able to alert someone?
That's another very interesting area that you brought up, so I'm glad you brought that up. The answer is no, not real-time monitoring, So the device stores this. If the patient has a remote monitor, and this is just an evolving technology that we've introduced in the last couple of years, then they will have a monitor. Usually it's at their bedside, and when they're within about 3 metres of that monitor, it can download the information. Now, it's not feasible for it to be continuously downloading the whole time. So what it will do is download at least once a day in 24 hours when the patient's in proximity to the remote monitor. And that's usually in the early hours of the morning while they're asleep. The device wakes up, interrogates it, and if it sees that there's been an arrhythmia like this, it then sends that information to us using the mobile phone network. So the home monitor has an inbuilt mobile phone receiver in it, and it sends us a transmission. So we will usually get it the next office day. If it happened in the morning, the device may have already picked that up, so we might get it within just a couple of hours. So I have had the case where a patient had a shock from their device. And in fact, what happened was that I was just at the airport about to board a plane when I got a phone call from the monitoring centre saying your patient's had VF and had a shock. So they were able to give me the patient's number. I rang him, and he answered the phone, which was a good sign. And I said, "How are you?" And he said, "Oh, okay." And I said, "Anything happened this morning?" And he said, "Oh, I just fell out of bed. I woke up, I was going through my emails and I fell out of bed." And I said, "Do you think you lost consciousness?" And he said, "Oh, I'm not sure." And I explained to him that in fact he had had ventricular fibrillation and a shock from the defibrillator. So presumably he had lost consciousness and wasn't aware that he fell out of bed. So the answer is not real-time monitoring, but very soon afterwards, if they've got a remote monitor. Now, not all patients have a remote monitor, and older devices may not support remote monitoring. So it's an evolving technology. But and what's for the future with that, just out of interest, is that some of the devices will now be going Bluetooth, which means they will have a monitor in their pocket via their mobile phone continuously. So we may get even closer to real-time monitoring with the advent of that type of mobile phone Bluetooth to your own device monitoring.
It's a very interesting space for other heart phone stuff as well. Mr. Pearce turns out had actually had a lot of episodes in the last few months. Almost all of them stopped by themselves. And he doesn't recall having had shocks, but most of them had also occurred overnight. So he'd obviously slept through runs of VF and VT, which you see as well. Or the tale of people falling out of bed, you hear a lot as well. So that throws out to everyone. What are you going to do with them next? I can throw out my fellow panel members as well, but what do we do with man in this situation? He's had lots of runs of VT, not having had them previously. I mean, he's gone 20 years since his bypass operation, you recall, way back then, with no problems. He's had his defib in now for, 10 and a bit, updated last year, but he's now getting runs of VT. It's probably simpler stuff than that, but yes, it's out there. Yeah, there's a very simple one. Check his electrolytes. What other things drive VT? Sorry? Check his medication. There's something pro-arrhythmic in there. I'll go through the list again. There's nothing too hazardous in his collection there, but that's a fair thing to do. Particularly, you think about some of the tricyclic antidepressants and stuff have a theoretical, like inducing QT prolongation, but it's not anything too hazardous in that front. But absolutely, yep. Sorry? Yes. Mr. P has a very long, complicated Eastern European name and does like his vodka. So you do wonder what that's done, what that's done to his cardiomyopathy as well. Thyroid function. Yeah, more the atrial arrhythmias, but I'm sure it does definitely stir up ventricular arrhythmias. I had a patient just last week before. He got thyroid toxic storm from his amiodarone, which has been used to suppress his atrial fibrillation, and got VT as a result of that. And it kept going until the point where we took his thyroid out surgically. Then it settled down the very next day. He was on lignocaine infusions plus his amiodarone, plus prednisone, plus carbimazole for his thyroid, and still getting VT. Took thyroid out, and within a matter of hours, it all just went away. It's a very definite possibility. Other things about this man's got an ischemic cardiomyopathy. Could he have had new ischemic events? Or has his ejection fraction just declined from whatever reason, and the increased sort of scar burns made him more prone to VT? So organising an echocardiogram at this point is reasonable to do as well. And probably want to reassess those 20-year-old coronary grafts in some way or another. So, I'll go with the patient there. there's not much to find in the examination at the time. One thing you should always do is beta blockers are the single safest, best thing you can do to suppress tachyarrhythmias, particularly VT. And so you increase his carvedilol from 12.5 BD, it was only a halfway dose, up to 25 BD. Generally recommend in patients who are over 85 kilograms, you want to get to a target dose of 50 BD, and that was done progressively, but the story does sort of go on around that anyway. Don't go jumping up too fast. His blood pressure, as you saw back there, was quite high, and his heart rate was reasonably fast, so that bigger jump was probably safe as he's along down the track. Generally, I tend to go in smaller increments rather than larger increments, just for the sake of safety. It's kind of an interesting side note that was published last year about how all of our heart failure trials have been coming through, and there's been a lot of unsuccessful ones over the decades, but even with the more recent successful ones, overall the rate of sudden cardiac death has been declining in heart failure management. Some of that's because of devices like ICDs getting implanted, and some of it's just heart failure medications to reduce the risk of sudden cardiac death. So it's always an opportunity when you had VT to optimise their heart failure medications, get them onto those target doses, make sure they're on the best available medications. So he also goes on to have a myocardial perfusion scan, to confirm coronary patency. His echo shows his ejection fraction, fortunately, hasn't changed very much. It's in the low 30s, about 32%. His electrolytes are all fine. So the myocardial perfusion scan, had an inferior perfusion defect on stress, but a normal ejection fraction. And why it was wrong from the echo is uncertain, but they do differ from each other at times I've seen. So he goes on to have an angiogram, I hope it makes sense. And I'll try and show you some of those pictures. Camera to come on those, perhaps. This is a view of his native left coronary system. You can see a few sort of stenoses there, and more importantly, you can see this very tight stenosis right here from the vein graft attaching to his circumflex. Let's go to the next slide. Is that the next slide? Just another perspective on the same. Another tight stenosis there in the circumflex. Next one. Same one again. And just another view of the same. Here we go. And the big money one, which fits with his myocardial effusion scan. And this is supposed to have had a vein graft to it, and that vein graft wasn't found when they looked. This is his Lima to LAD, which is useful because it shows the very good Lima graft running down. If you look at the very end here, you can just see filling of the right coronary artery via that graft from the Lima. So he's got an occlusion in his right coronary artery. And that was the report that came out of that. And I might ask what we'd do with that.
Scott, can I just make a comment here too? I might add that we haven't seen this case, the other people in the panel, so what you're getting is a sort of spontaneous discussion, and we won't all necessarily agree on everything. But one of the things I was just going to mention there, I said when we looked at the electrogram that there was a polymorphic ventricular tachycardia, so changing morphology from beat to beat or every few beats during the arrhythmia. The two types of VT that we discriminate are monomorphic ventricular tachycardia, which has a uniform electrogram and a uniform shape on the QRS from beat to beat on the 12-lead ECG, versus a polymorphic ventricular tachycardia. The differentiation can be helpful in sorting out these things, because if it's monomorphic ventricular tachycardia, ischemia is important, but in fact that arrhythmia is very much based on a reentrant arrhythmia within myocardial scar, or at least the persisting viable channels within myocardial scar. And often correcting ischemia may improve the tolerability of the VT, but by itself it wouldn't usually cure monomorphic VT. So it doesn't diminish. Doing the coronary angiogram, you want to have everything on your side in terms of treating these arrhythmias. But I wouldn't be satisfied if this was monomorphic VT in attributing it just to myocardial ischemia and say, oh, if we do a stent of the right coronary artery or a stent of one of the grafts, that's going to cure the VT. With polymorphic VT, then that's an arrhythmia that certainly can occur as a result of acute myocardial ischemia. So that treating any ischemic event at the time will potentially help to prevent that from recurring. So in this case, I'd be sort of particularly keen to see if there's anything that can be done in terms of revascularization. The only thing about that I might add about that is that sometimes this arrhythmia occurs in the setting of extensive scar and LV dysfunction without necessarily being acute ischemia. For instance, we see it in non-ischemic cardiomyopathies. Again, treating the ischemia isn't always a guarantee it's going to alter the arrhythmia. And the second thing is that sometimes you can have monomorphic VT at the start, which then degenerates into polymorphic ventricular tachycardia or ventricular fibrillation. And that's a relatively common thing. So you have to interpret all of this fairly carefully. But they're the sort of points that I'd like to bring out about what we're seeing here at the moment.
I was just going to comment on the angiogram. And I'd agree with what Wayne's saying, that as ischemia is part, but not the whole answer to the equation here, I think. On the angiogram, he's got 3 territories, the LAD, the circumflex and the right coronary. The right coronary is occluded. I'm presuming the graft to the right coronary is also occluded, yes, because we didn't see it. And we're also, there was this, I think Scott pointed out, there's a stenosis or a blockage in the vein graft to the marginal. So he's got 2 territories that are ischemic. He's got a patent lemur on the LAD, which looks in good shape, which invariably they do at that point. So he's actually got, I think it looked like he had vein grafts to the circumflex and the right originally. Right. So one of those is occluded and the other one's stenosed, and it's so we're now talking about a 20-year-old vein graft as well. On his myocardial perfusion scan, which is helpful, that gives us a functional assessment of what those blockages are doing. Are they causing ischemia, or is that area scarred or dead and not going to benefit from revascularization? So the nuclear scan showed that there was inferior ischemia, so that he does have ischemia as part of the issue here. So he is actually looking at his findings if we were interested in completely revascularizing him, if we thought he was a candidate for that, and we're discussing that, he could look at a bypass graft a redo bypass graft to the right coronary PDA and the circumflex. The circumflex lesion itself would be in fact stentable, but we wouldn't, very unlikely to be able to reopen the right coronary occlusion. So, and both of those targets look reasonable, so a redo bypass operation is reasonable. I mean, it would be also nice if in our history we got a history of symptoms that might benefit from revascularization as well. I think that actually gives you a little bit of that clinical information, gives you a bit of motive to proceed as well. So he would benefit from that. He's also a diabetic, so it's very clear now that that diabetes are not a good group for multiple stents. Bypass graft surgery gives much better long-term outcomes. So what we'd be hoping, if we did do a bypass, would be to reduce his ischemic burden and go part of the way to helping his LV function improve and to reduce his arrhythmia substrate.
He made life difficult by not wanting a redo bypass graft because of his being scared off by the surgeon, his low ejection fraction, unfortunately. So he actually went on to have a PCI to the circumflex and marginal, the native vessels with drug-eluting stents, and then to a CTO PCI to his right coronary artery with a drug-eluting stent as well, and got full native revascularization, except for his LAD, which is still bypassed by the lemur graft, and had a good result from that, and that we had no more VT after that. But 6 months after that, he's got class 3 breathlessness, which he's really had all along. Doesn't wake up short of breath, doesn't get paroxysmal nocturnal dyspnea, but gets episode chest tightness at rest times, not exertion. His blood pressure is touched on the high side there. His heart rate's reasonable, and he's got this big truckload of medications there. I might invite time to look at that huge list of medications, because there are many there, and see what people might want to do next with him. Go for it.
So it was my first impression, the patient coming from Sydney. We don't know anything about the follow-up patient before. We don't know the full history. And certainly the one thing striking for me that he wasn't on optimal medication from the beginning, as you mentioned, or beta blocker dose probably should be increased. Always concerned patient being on the cancer channel blockers with the poor LV function. Much better to increase the beta blocker therapy and give the higher dose other medication other than this particular one. And certainly what is striking is lack of statin.
He's got a statin there in the middle line. Well. Rosuvastatin's there at 40 milligrams.
Sorry.
It's a messy, intentionally a complicated long list because I'm trying to...
Yeah, but certainly I think the medications, there's a improvement on the medication list, especially probably the calcium channel blockers. And so I agree that this sort of patients usually needs to be on a dual antiplatelet medication, perhaps indefinitely, regardless of the procedure. And they probably require some regular follow-up, and I think this was missing. Probably this could be definitely pick up areas there.
We've now got to, it's almost a year being back in Brisbane, not quite. With not much other than getting his ICD checked and his stent put in, yep.
Scott, can I ask you a couple of questions about his medication? One is he's on a calcium channel blocker. How do you feel about calcium channel blockers in patients with LV dysfunction and heart failure?
So you definitely never use verapamil diltiazem, as they are known to be cardiac suppressant. Amlodipine is relatively safe. And in his case, he ended up on amlodipine because his blood pressure was actually very hard to control. And he's actually, despite in the end being on maximal dose perinappril, 10 milligrams BD of perinappril, which is sort of super maximal, although we tend to do a bit of that, and 50 milligrams BD of carvedilol, which is not strictly super maximal, but certainly more than the standard PBS quantities, and spironolactone, 100 milligrams a day. And amlodipine has some anti-anginal properties, and this chest tightness, which while I describe as though it's the first time it's happened here, is an ongoing thing. It became as a bit of an anti-anginal agent that's not going to make their heart failure worse. Other ones, lercanidipine, nifedipine, for example, don't really have that angina data or the safety data in heart failure, although they're probably not as bad as diltiazem, verapamil are. But certainly you stop diltiazem, verapamil without hesitation in these patients.
If I can ask you, would you like to use the hydralazine, for example, instead of amlodipine?
So if it's pure blood pressure control you're aiming for, I think hydralazine is absolutely the choice. You do hydralazine and long-acting nitrates, as you suggested there, and he hasn't got a long-acting nitrate in that mix. So a better choice would be perhaps to put in the long-acting nitrate and the hydralazine in place of the amlodipine. And this is kind of what we got landed with when we found him, but this is kind of the logic I think that's been applied along the way.
He's on the ivaprodine as well as a sinus.
He's somewhere down there in the depths, which is a way of maintaining a good, reasonable rate control. Knowing that ivaprodine, if you've got a heart rate over 77, will improve your mortality, in sinus rhythm that is, improve your mortality in heart failure patients.
And Scott, he's on the combination diuretic therapy of a loop diuretic with a furosemide and a thiazide. Do you want to just comment on that combination?
Yes. So obviously loop diuretics are the most effective in terms of getting rid of large volumes of fluid, but you often find you get to a point where you need to block other parts of the nephron basically to get more fluid off, and people seem quite resistant to it. So often blocking the nephron at multiple points achieves more than really big doses of just a loop diuretic. Always I use the loop diuretics as my first line agent, and that's furosemide for the most part. Occasionally you get ethylcrenic acid. You'll find that they come through the Prince Charles Hospital. We use bumetanide a bit, which is another loop diuretic that's not PBS listed in Australia. It's not terribly expensive, but it's just hard to get hold of because of its better absorption than furosemide. But either way, when you get to those doses of more than sort of 80 twice a day, I'm not sure if I'm only got 80 a day there with furosemide, I'll often add in a thiazide diuretic just to get some added efficacy without getting the mouth dryness, which often comes with very high doses of loop diuretics. And that's the other sort of eternal problem you get, is the higher you increase people's loop diuretic doses, the more likely they are to get feelings of dry mouth, and the more likely they are to drink more, and then this sort of circular spin of more loop diuretic, more dry mouth equals more drinking, equals more loop diuretic, equals more drinking, and never quite get under control. Yeah. We'll get to that. This is 2014. We hadn't invented Nutritional yet.
Current day and age of the situation, would you use that or would you wait for the combination?
Yes, is the answer. I would use that. Yeah, we'll get a bit further on. We get a step further in time, a bit further with that. Yeah.
What about the high dose as with the spironolactone?
So that's something you would get nervous about because obviously that can really put an impact on both causing hyperkalemia and worsening people's renal function potentially. But I think if you watch it very closely, you're safe. The trick is to check their electrolytes out every time you increase a dose. I would not go more than 2 weeks after increasing either an ACE or a mineral corticoreceptor intake like spironolactone without checking their electrolytes. Some people seem to tolerate massive doses like he did. Some people, you give them a little bit of a whiff of an ACE and a whiff of a spironolactone, some of them potassium-6, and the kidneys have gone off, and you've just got to watch it closely. And it's unpredictable. I don't find there's a particularly predictable way of doing that. I guess large men often tolerate the high doses of spironolactone, for example, and he's one of those.
The purpose of the fish oil 3 grams there?
That's a really good question, isn't it?
I wonder whether he's taking all his medication.
He's remarkably meticulous about his medications. Fish oil is a funny thing, and I guess in this space, A, the man is on 40 of rosuvastatin, 10 of ezetimibe, and I think his LDL is still marginal. It might help a little bit with cholesterol management. B, there is a GIZI HF trial which showed a small 2%, but a statistically significant 2% reduction in mortality on 3 grams a day of fish oil, which is kind of why we left him on it.
Is that going to increase his risk of bleeding?
Not terribly. I suppose if he's having multiple bleeding events, yes, but if he wasn't, and therefore wouldn't worry about it too much. If anyone else has strong feelings otherwise.
Yeah. And Scott, the other thing, if he continued getting VT at that stage, then the question of antiarrhythmic drugs. One of the questions that's often raised is that, well, why not put all of these patients on amiodarone, and then they will be less likely to get VT, and the question of whether that's going to, in fact, prevent them from getting VT and improve their long-term survival. So that was a question that's been answered with a randomised controlled trial, and the answer is that it has no effect on mortality whatsoever. So one of the things that was raised for quite a while until the Scott study was done was whether we should use primary prevention amiodarone to try and stop these patients dying suddenly. So at least we know for sure that there's no point in doing that, and that's why he wasn't on amiodarone and he received an ICD instead. But if he continued to have VT despite the high-dose beta blockers, then amiodarone has a role to play in that situation to help suppress the frequency of the VT, and it can be effective in doing that. But of course, it's against the negative side of amiodarone of long-term adverse effects, which are both dose and duration related. So it's a symptomatic treatment basically, rather than having any prognostic effect. But by far and away, our key treatment is beta blockers, which in fact beta blockers and ACE inhibitors, in the studies that were done, reduce the risk of sudden cardiac arrest as part of their effect. So in fact, they do have an antiarrhythmic effect in that situation, which you've already pointed out.
I was just going to comment on your slide, Scott, at the moment, because I think we're sort of asking a question. He's in 2014. He had arrhythmias and obviously ischemia and had multi-vessel stenting. So he's actually New York Association Class 3 breathlessness, which means he's getting breathless just walking short distances for the audience's benefit. So he's very, very symptomatic. And he's getting chest tightness as well. Which you might say he's getting it at rest. It's not coming on an exertion, but he's probably not doing enough to get exertional angina. So you'd have to be starting to think about recurrent ischemia, and I think I probably gave the wrong answer before, that I would have recommended a bypass and he had PCI, but I think the reason that we don't do PCI in multi-vessel in diabetes is because diabetes is a different animal from all the other problems we deal with. It seems to, and I don't think we understand it all yet, but I think we've all done multi-vessel PCI in diabetes only to have even drug-eluting stents, restenosis. So recurrent ischemia is a possibility here. We'd probably also want to reassess his cardiac function again because he's very symptomatic, so we haven't really produced a lot of benefit for him yet. The third thing was in his arrhythmia menu, he has atrial fibrillation as well, which we haven't mentioned and which could become recurrent. So I think a reinterrogation of his device would be very useful to see if he's having further atrial fibrillation that might be contributing to his breathlessness. And we didn't actually discuss whether he should be anticoagulated because he probably should be with the AF episodes he had before.
So that's a good question there, isn't it? We might as well address where we're at. So he's 6 months post his PCI now, still just on dual antiplatelet therapy with this background of AF. And his risk profile for stroke with AF is fairly substantial. He's going to get Chad's vascular marked for his age. He's going to get marked for his coronary disease. He's going to get one for his heart failure, one for his diabetes. Must be at least 4. We've got 2 or up to 5 now. So Chad's vascular is at least 4 or 5. And hypertension, we even get to 6. So substantial risk. Should we just add in a NOAC to this mix? He's got relatively normal renal function, or would we drop something in the process?
What are we trying to do here? Coax a few more months out of this man's dying heart. I mean, so far, over 4 years, a brilliant example of fine-tuning cardiac management for this man. But he's got a dying heart. You're going to coax a bit more out of it by more fine-tuning, very, very skillfully. But I feel he needs to be confronted with the fact that he's standing on a parapet on one leg in a wind. And it might be a benefit if someone really confronted him with that, because I wonder whether he really knows what a precarious situation he is, and that even a modicum of weight reduction might help to take the load off that dying heart and give him a slightly, and gradually introduce pattern of exercise very carefully when it's appropriate, might just give him more benefit than any more fine-tuning.
It's worth noting, actually, that you've raised some good points there, that we have, over the years, and I didn't meet him quite late in this, till sort of the 2013 kind of phase, that he's been told to lose weight over that time, many way at times. And for the sake of simplicity, I've dropped off that. We've tried Byetta for him, we've tried empagliflozin for him in tools to try and help him lose weight. But he's rigidly managed to maintain his weight in the high 110s. And despite the fact he would be eligible for a transplant if he was not maintaining a weight in the high 110s, in fact got his weight under the 100 kilogram mark or a BMI under 35.
But what an anesthetic risk.
Well, that's why you need to lose weight, isn't it? But you're absolutely right. And there's, I don't know, he does all the usual excuses patients give you for not losing weight.
Because you're talking about 6 months post-PCR and you're trying to anticoagulate. Shouldn't that be talked about with
Back at the time of planning, yeah. I was just raising now as an opportunity to do it, yeah.
Of course, can I just ask a question? With the testosterone, obviously that will be for his lifestyle benefit. Is there any long-term, should we continue that if it is just to make him feel better? Or is there any adverse side effect if you keep using testosterone?
We have left him persisting with it because it does improve his quality of life. I don't think it has any particular adverse consequences in this circumstance. Yeah.
So you wouldn't, in terms of his electrolytes and something,
No, I wasn't going to worry about that particularly. Pardon? No, doesn't. Whilst it might give him gynecomastia, that's not the reason. I think it's probably his obesity, sleep apnea, because he's got untreated sleep apnea, that's causing hyperprolactinemia, which is causing his primary hyperaldosteronism, or secondary, what do you call that? Sorry? Not treated. Doesn't tolerate the mask.
We had a case where somebody had carried with ETs, arrhythmias, eventually ended up being sleep apnea, kept triggering off these arrhythmias, and she was in hospital for quite a while.
Got that.
Yeah. That was one. The other thing I was going to bring up is there's a cardiocentric approach to things, and there's a neurocentric, and there is a diabetes-centric approach to patient management. What we tend to see in general practice is there's renal failure on one side, and you've got Przemek and thiazide on one side, and then you've got hypoglycemia and diabetic.
with these heart failure patients,
stuff needs to be. A lot of times, if renal guys are doing their thing, cardiologists doing their thing, and the renal stuff gets a certain angle, and cardiology gets a certain angle of Frismont. So I think the liaison becomes very important.
yeah, with these heart failure patients, because the multidisciplinary kind of involvement becomes really crucial to their care, and something we engage in very much. That diabetes is intrinsically tied into heart failure, and likewise obesity. And I haven't put in slides about things on the way using empagliflozin, the drug I tend to use for heart failure management in diabetic patients, or diabetic management in heart failure patients. I don't want to word that question because of its evidence in that state. And there's an example of how you need to look at the whole picture of the patient. The renal dysfunction and the concepts of loop diuretics and all their medications is also a real fine balance, and getting a sensible nephrologist involved in the process avoids that trying to treat a creatinine and treats the patient instead, which is another danger we see all the time. And there's a constant bugbear of patients who live remotely to us and just see it occasionally, is they rock up to some regional centre, somewhat fluid overload, for example, get hospitalised, their creatinine goes up by a little bit, they stop the furosemide, send them home, even more fluid overload, and they arrive in hospital. And then the cycle of continuously edematous patients who don't ever feel well because no one ever gets rid of the fluid. And we bring them down once, hospitalise them, get all the fluid off, and they go home feeling $1 million. Yes, their creatinine may have risen a fraction, but creatinine is a number, it's not an actual marker of your renal function. It's a marker, not your renal function.
So his ejection fraction is less than 40%. So
Correct.
He would be qualified for the Army kind of medical.
But it's too early in time. Correct, yes.
I was just going to answer the gentleman at the back's question before, because I think that's an important approach to heart failure management. I mean, we've made some inroads on prognosis over the years with a long list of things. And I think so people are living longer, but the prognosis is still poor. It's like having a cancer, so it's a very similar sort of prognosis. But what we have done, though, is we've made major improvements in quality of life. And I think one of the things we've found is that if you've got reversible factors, ischemia, LV dysfunction, arrhythmias, by improving those, you bring patients from this level to that level, and interestingly, they often just stay there. And they can do it, and I've seen this numerous times now over the years, where you think someone's been written off, and they come along and you do these things, and they suddenly live another few years with excellent quality of life. I remember when we were just starting the heart failure transplant program out at Prince Charles. Andrew Galbraith started it, and he said, we've got all these people on the waiting list for transplants. We're now taking them off because they're a lot better on beta blockers. They all got better, so we're doing less transplants than we thought. And all of a sudden we had all this cohort of people who were surviving with good quality of life on beta blockers. And so that was a lesson to all of us. We didn't think that would happen at the time.
It's a remarkable thing to look back at our transplant data, actually, that in the transplant program started at Prince Charles in 1990. The peak numbers we transplanted were about 1995, 96, and they were doing 25 a year at that point in time. And then the beta blocker trials came out just a couple of years after that, and suddenly the numbers went from 25 a year to 10 a year, and they've remained pretty stable since, barring a few blips, 10 to 12 a year. So they're a remarkable, in combination good heart failure therapy, how much better outcomes are.
Scott, can I just introduce the concept of compliance? He's on the right, he does this in Palka, he's on the Aberdeen, and he's pulse rate 68. And he's probably not patients 68 because I've been 60 as a backup. So he's not exactly big a block, despite being on lots of drugs and making that stuff. So, but I'm just introducing compliance in patients who remain refractory or veteran.
So what I say with him, and on that topic of compliance almost, is research his volume stats, because his JP was elevated 6 centimetres, his lung fields were clear, heart sounds were unremarkable, and no pallidemia, but he's clearly fluid overloaded there. And what we found over the years with him, and this is sort of where it first really started coming to people's attention, was that when he gets fluid, he gets anginal type chest pains, with this chest tightness at rest. And at that rest, because he doesn't walk very much. We did actually re-image his coronaries at the time, and his coronaries were still patent. Those drug-eluting stents were, in fact, working quite well, and there were no new lesions. But the stretch of a full ventricle and the increased workload of the ventricle may induce a microvascular ischemia, which you can sometimes see in troponin rise in patients who've been admitted for heart failure. And the secret was keeping the fluid off. And this became a recurrent thing over the course of the next few months. I'm dealing with the next months and years, dealing with fluid status. So that was done. Went on to an angiogram anyway, because it kept happening, but still unremarkable. Imaging got added, which was mentioned earlier, as another way of helping manage both his blood pressure and his afterload, which is often very helpful in these heart failure patients. So when you've still got high blood pressure despite maximal dose beta blocker, ACE inhibitor, that's when you should start thinking about long-acting nitrates and hydralazine. So long-acting nitrates got added at this point in time, which did help a little bit.
So nitrates are helpful with the patient with the heart failure and fluid retention with impaired LV systolic function. So they're actually not indicated for the treatment of heart failure of preserved systolic function. Tell me if I'm
it's
right.
a REF perhaps, yeah.
It actually could have the adverse effect, these organic nitrates. So they're recommended only to patients with the poor LV systolic function. Yeah.
Yep.
And if I could just make a point, sometimes devices can help us with this problem of pulmonary congestion as well. Some defibrillators, and increasingly more defibrillators, incorporate something called transthoracic electrical impedance. So it emits a little electrical signal from the tip of the pacing lead and measures the electrical impedance across the lungs and the chest to the device where it's implanted in the pectoral region. And that correlates very well with the degree of pulmonary congestion. So the more congestion you have, the better the electrical impedance. Basically, it's salt water rather than air for transmission of the electrical signal. And so the electrical impedance falls, and that's a measure of increasing pulmonary congestion. And so that's very useful in this sort of patient. We may be able to monitor and have the device actually send us an alert if it's crossing what we predefine as the level of pulmonary congestion that we're willing to accept, and it'll send us that through remote monitoring. And this induces a whole area now that's emerging of device monitoring of heart failure, not just as a defibrillator, but all other sort of parameters as well. And maybe you're going to lead us into that with the discussion.
Yeah. So this is, jump forward a few years. He's been hospitalised multiple times. One example that was quite striking was we lost 7 kilos in the course of 18 hours of fluid, indicating he's not the best in sticking with fluid restriction. But back in outpatients, only a few weeks later, 3 kilos heavier. We've done this thing with doing day procedure unit admissions for furosemide infusions, to give them 250 milligrams of furosemide over the course of 4 hours, and it can be quite effective for these patients to sort of try and keep them from being formally hospitalised when they just cannot stick to the fluid restrictions, clearly. Let's kind of give you a sort of snapshot of his hospital stays and how often this man's bouncing in and out of hospital with his heart failure, which is lots, as you can see. I mean, quick tally, that's 1 per line. So now what do we do with him? He's 64, or he's 64 now, so he must have been, go back a couple of years, 62, like that. Which is a good question. That's why he was considered transplant eligible as well.
I've got one comment. So we know very well in our practice to manage patients with fluid overload is exceptionally difficult, and as you know very well, we're pushing the dose of the diuretics and loop diuretics in particular, keeping small dose of thiazide probably predominantly to prevent any resistance to the diuretics, which we believe this maybe is the case, but we don't have the data about this. But we also, and this is what was pointed as well from one person of the audience, that this is multidisciplinary approach. So patient needs to lose the weight and diet change. We found also that it's very helpful to have the proper treatment for the sleep apnea. This is probably one emerging approach how we can treat the patient. It's not only treating sleep apnea as such to prevent tiredness during the day, but also improve the heart muscle function. We found by titrating the pressure in the lungs during the night, improve the right and left ventricle filling indices and also systolic function, and might reduce even the dose of diuretics. So that's why we have to approach this sort of approach doing all these things. So assess patient weight, hypertension, fluid retention, and also looking for other causes of, for example, sleep apnea.
Yeah, that's something we always worried. He's not tolerant of sleep apnea, unfortunately, which is why we're stuck with the situation.
And Scott, just one other comment. I'd like to see an ECG if it hasn't been done, in recent times, particularly looking for left bundle branch block. And the reason for that is that if he's developed a conduction anomaly with left bundle branch block, and something like a third of these patients will have left bundle branch block, then it opens a further therapeutic option, non-pharmacologic, with adding a left ventricular lead to his defibrillator and using cardiac resynchronization, pacing to try and improve LV function.
And you see spectacular results of that often in these patients when they've got a left bundle branch block. Totally can transform them. Often that seems to be the single thing. You get all these good days of heart medication, nothing still moves, and then you stick in cardiac resynchronization therapy or by ventricular device, and suddenly their ejection fraction picks right up, can normalise. So other things you should always check on this context is check on their iron levels, check the thyroid function, don't forget to check their HbA1c, check they're taking their pills, check they're sticking to their fluid restriction, check they're not binge drinking on weekends. I want to highlight his iron studies at that time and see what everyone thought about his iron studies. Is anyone happy with this? Let him go. Yeah, so this is one of those traps of haematologists have created for us, I think, which is why I've drawn to everyone's attention. Yes, look, it's nice, it's green. Yeah, serum iron, you don't believe, that's just a marker of how much iron they've ingested in the last 24 to 48 hours, so it's a useless test. I don't know why we include that. But transferrin saturation and ferritin are both very useful markers. They both give you hints of what their storage situation is like. He's got quite a low transferrin saturation. They're not below normal. Suggesting there's not much iron there, and his ferritin's on the green still. Now, in fact, when you've got some inflammatory disease, and this is an improvement in heart failure and renal disease, ferritin of less than 100 is actually iron deficiency. The problem with the iron measures we have are that they're largely based around haematologists' desire to stop people getting anemic, and you can well not get anemic while still being profoundly iron deficient. Iron is sort of like when you think about blood flow delivery to the brain, where the brain is the last thing to lose blood flow in circulatory system. Well, the bone marrow is the last thing to lose iron in sort of the ions management state of your body. You'll deplete iron in your cardiac muscle and other and skeletal muscle well before you'll start depleting it in your bone marrow, and become effectively functionally iron deficient as a whole, and therefore have impaired oxygen metabolism as a whole well before you become overtly anemic. And the thresholds that we should be treating to are in fact much higher than you would think. And the ferritin of 100 is less than 100 is iron deficient in a heart failure patient. Likewise, the ferritin of between 100 and 300 with a transferrin saturation less than 20% is functionally iron deficient, and we need to address that. And looking through my heart failure clinic patients about this time last year, we found that 50% of our heart failure patients, in fact, were iron deficient by these definitions.
I could put some comments here. So this is what we call the functional anemia. So IgB is within normal limits, and iron level, perhaps iron saturation is low. So I think it's still questionable whether we should treat this how extensively as we should. Certainly the easiest way is to give the iron infusion. It's I think depend on the long-term observation. I think you always worry about this group of patients, if they go truly low iron level, you overload them with the iron. You might actually cause the problems in the long term. As we know very well, iron could deposit in the myocardium, could cause the hemochromatosis. So this is for the long term. So the short term could be some transient benefit for the symptoms, but long term might be some adverse effect. And also the majority of this patient got actually some problem with the GI bleed. They might have the small polyp bleeding there. In my practice, they're very often undergoing redo, colonoscopy, and they always find something. And they treat this, and iron deficiency anemia is stabilized later on. So it's a very complex area, certainly growing up at the moment. And perhaps we got some more new data coming from your study as well. So,
Oscar, I tend to, by contrast, treat iron deficiency quite readily. And I might just skim through these because in the interest of time. But there's multiple mechanisms in which patients get iron deficient in heart failure. There's polyps and bleeding, which is a common one. There's a bunch of, malabsorption becomes a huge issue in heart failure patients. Their diet tends to change because they just don't feel like eating much, and they don't eat heavy foods like red meat, and so they get iron deficient from that reason alone. We stick them on a bunch of blood thinners so they bleed more readily, and the net result from a huge variety of reasons is that they end up somewhat iron deficient. What the observations that have been made is that the lower your ferritin is, the more symptomatic your heart failure is. That it's more important that you be worse that you're iron deficient than that you're anemic, in fact, in terms of heart failure symptoms. But obviously being anemic and iron deficient makes you even more symptomatic again. And that if you're more iron deficient you are, the more likely you are to die. And is that because of the iron deficiency? Well, we don't really know the answer to that, but it's suggestive that that's the problem. In rats with iron deficiency, you get left ventricular hypertrophy and ventricular remodeling, presumably because of a less efficient myocardium. And that, of course, makes the whole heart even less efficient in what it's doing, worsens the situation. If you treat people with IV iron, that's the safest, easiest access one is ferrous carboxymaltose or Ferinject. You will improve their 6-minute walk distance, or the VO2 max in that study, and improve their 6-minute walk test. So that tends to be where you go, because what I tend to advocate is iron carboxymaltose. You can do it in general practice quite easily. It's a 15-minute infusion without the usual risk of complications that goes with that. And improve 6-minute walk distance, reduce risks of hospitalisation due to heart failure. I think this is bearing in mind a short-term study. So Mr. B was given an iron infusion and felt tired and achy for the next 2 days, which is a really common phenomenon. I don't know how you guys have given iron or Ferinject to your patients. I find most of them feel a bit like they've had the flu for a couple of days, not in the runny nose kind of thing, but that achy and tired and run down, but generally feel much better within a matter of weeks after that, and that's sustained for a while. In some patients it's quite remarkable, and I must say the older women are the ones who seem to get the most benefit in the energy improvements, but it applies equally across the board. The other thing we have is this thing called the cardiomembers, and I'll talk about that. This is one of these instead of the adjunctive ones, which are a whole wonderful discussion as well, things that you can add to your ICD or device to get more information out of it, and that's a talk in its own right we should do. It's a device we have gaining access to actually directly monitor their pressures. That is a cardiomembers. It's about the size of that big in terms of the actual pressure sensor there. And it sits in the pulmonary artery. We implanted it at the time of a right heart catheter study and feed this thing into their pulmonary artery. And what happens is it's got no battery in it. You can see there's no battery, no space for a battery in it. It lasts forever. It's just a little capacitor. And they get given this pillow to go home with, which you can see in the bottom left there. And that pillow transmits a radio frequency to the device, which in turn generates a little electric current, which bounces the current of radio frequency back with higher pressure, squishing the capacitor down more, generating a higher frequency. And that gets translated to an actual pressure reading and gives you a tracing of what the patient's pressures are like. It's proven to be a highly effective tool in terms of reducing heart failure hospitalisation, irrespective whether they got heart failure with preserved ejection fraction, as an ejection fraction of over 45 to 55%, or reduced ejection fraction. It still reduces the risk of hospitalisation by 30 to 40%, on top of maximal medical therapy. It's a highly effective tool. And it does that because you see the pressures rise as they start to retain fluid well before any other symptoms manifest, before their weight goes up, before they start feeling it. Typically a rise in pressure occurs 21 days in advance of a hospitalisation event. And I know this because in the study, everybody got a cardiomem, so everyone was doing their daily readings, but only the treating physicians only got the results in half of the patients. So you could watch the patients decompensate, end up in hospital and go, oh look, the pressures rose before that happened. But it proved that the treatment worked because it wasn't the placebo effect of putting in a device, it was the actual pressure readings and adjusting according to what the device was saying. The idea being, of course, if your pressure starts to rise, you can say, oh, they need more diuretics, and you increase their diuretics to get rid of the excess fluid, and they'll keep them out of hospital. They're highly successful. Mr. P gets that. He does quite well. After all those hospitalisations you saw on that previous graph, he doesn't have any for 6 months, but he's still quite breathless. Reminding you of what his background is. Again, just to go through it, his HbA1c is deteriorated with time, you can see. And he's on that somewhat altered list of pills there. You can see we've added empagliflozin into the mix there because of the HbA1c being off, knowing that empagliflozin reduce your risk of heart failure, death or hospitalisation by about 40%, at least in a primary prevention setting, which is kind of good enough. You can see he's now on hydralazine and Imdur, a more appropriate mix of medications. And these perindoprils gone missing. These perindoprils gone missing for a reason. This is Mr. P's pressure tracing there. And those wiggly lines, the red line represents his PA systolic pressure, the blue line is mean pressure, and the green line is diastolic pressure. Basically, we treat to have a mean PA pressure between 15 and 25. Quite hard to get the flow of trends there, but you can see here on the bottom, which is the overall trend, is being gradual upwards rise in his pressures. It's probably why he's getting more breathless. He's got a high wedge pressure as the hypothesised mechanism. We've been giving him increasing doses of diuretics and made his kidneys very unhappy over that time. So what do we do next with this thing? I put the suggestion previously. This is why his perindopril was discontinued. You can see why we might be alarmed about this. This is us trying to get that pressure down. We give him escalating doses of diuretics until this happened when, ooh, that might be a bit too much. Now what? But we know he's got pulmonary congestion because he's got a high pressure there. And it's real. So the secret here is back to the very classical teaching of heart failure, is that in the end, why do you get high pressures and high pulmonary capillary wedge pressures, the thing that causes the breathlessness? And it's driven by the lack of blood being cleared out of the lungs. And there's many reasons why blood is not being cleared out of the lungs. One of them is there's too much circulating volume in the first place. That's where diuretics come in. The other is the afterload is too great in the heart to actually remove the blood from it with each cardiac cycle, and so it gets congested. So to reduce afterload, you need vasodilator therapies, which is what we're missing here. Obviously, the perindopril got discontinued due to the renal dysfunction, but it was a vasodilator. He's on hydralazine, he's on nitrates, he's on, for what it's worth, perhaps some nicorandil. I'm not sure it's much of a vasodilator or not. He's on his carvedilol, he's on furosemide. What else are we going to do? So kidney function has improved at this point in time by the time we see him in clinic. The BNP is remarkably reasonable. Blood pressure's all right. So we can start something now. Any new things we can try, since what we're doing hasn't been working so far? Yeah, I've done the Entresto pathway. So bring up the ESC heart failure guidelines to remind you, well, this is where they take things. We will get new Australian guidelines this year, which will be exciting stuff. But you can see just step down the thing there, go ACE inhibitor, beta blocker therapy, add spironolactone, still symptomatic, you're down in here somewhere, and you think about adding an ARNI, which is kind of where I'm going to take this pathway. You can also see that we've talked about avabradine, he's already on that. We've talked about CIT, he's got a narrow complex and isn't appropriate to that. So we're kind of left with what can we do here. ARNI is not this person, although it is ARNI, remarkably youthful ARNI in fact. ARNI is an angiotensin receptor blocker neprilysin inhibitor, or what you guys have heard muttered around the room call Entresto. And this is to remind you how it works, in a very short running out of time here. This whole, arguing the whole RAS system, the renin-angiotensin-aldosterone system, ACE inhibitors, ARBs, and mineralocortical receptor antagonists have all worked on that for years, and they're quite effective in reducing all sorts of things, vasoconstriction, sodium water retention, cardiac fibrosis, sympathetic tone, systemic vascular resistance. Everyone's heard about BNP, I hope, as a marker of heart failure. It's a very good marker of heart failure. But actually, it's a hormone the heart is secreting in response to excess volume, and that's the kind of thing we missed. It's the heart's way to try and make things better. BNP is a vasodilator. It produces diuresis, natriuresis. It reduces hypertrophy, reduces sympathetic tone, reduces aldosterone secretion, and reduces the negative vascular remodeling with it. So it has been an attractive potential target for years, but no one's had a way of doing it until the concept of Entresto came along, the neprilysin inhibition came along. Neprilysin blocks the breakdown of BNP and other natural retards, so you get more of that beneficial effects you were aspiring to, well, the heart was aspiring to achieve, while at the same time with the valsartan component of it blocking the renin-angiotensin-aldosterone system. So we stick him on that because it does improve in the mortality substantially. The combination endpoint of hospitalisation and death is reduced by 20% being on Entresto versus being on enalapril. Likewise, death from cardiovascular causes has similar sorts of results, and death from many causes achieves a similar kind of benefits. actually causes less renal dysfunction than the ACE inhibitors. So we sort of had a certain comfort, and maybe this is a good time to use it on him, given he clearly needed some vasodilator therapy. It does cause a bit more hypotension, I have to say, from my clinical experience, and everyone else's in the panel's experience has been. A lot of that's mediated by diuresis. Is that in your experience? They get dry quickly.
That's correct, and especially the patient got the high blood pressure, they respond better to the ACE. So I think he got clear indications at the moment. So I presume his blood pressure will be better controlled. As you know, the vasodilation effect will be beneficial for him. So he got all indications and could probably, I presume, he'll feel better with that.
So we started. I might have step through actually, just in the interest of time actually, and produced relatively good outcomes of him. And I'll skip through all this in the interest of time, because we do have other cases we can talk about, and say that's much. So overall, I guess the thing is, there's lots of things to think about in managing a patient with heart failure. We've talked about them around the room, which is important. Do stick to your standard heart failure therapy. That still remains the benchmark for it. There are an increasing number of specialist monitoring things we can do. CardioMEMS is out there. Using devices is definitely out there. Two of the device companies we're talking with now about things of using more than just impedance monitoring, but heart rate monitoring and other parameters to detect heart failure decompensation before it happens. And we'll be increasingly using those in the coming years, with CardioMEMS being like a last-ditch add-on therapy to that, which is still going to be available.
I'm just only asking you, I think this patient got a few times the right heart catheterization, that's correct or not? Could you tell me how many times, roughly?
I don't know, actually. A few of those. Two or three, anyway. Yeah.
That's very interesting, yes. And I think this is probably lacking all the time, because we probably used to do it, right catheterization, a long time ago, and with the development of ECHO, we're using less. But I'm pretty sure that's probably not the right thing to do it, and very often this sort of patient required not only angiography as such, but the right and left catheterization to assess the wedge pressure and to assess how much of the patients could be fluid overload, or could be some other, because there are specific medications for the primary hypertension as well.
Yeah, it's definitely do. We used to underdo right heart cathetering, and we're starting to do a lot more of that, yeah, for that reason. So I might hand this over now. Any questions, comments? Yes.
I'd like to go right back to the very beginning.
Yes.
What are the clinical indications for using an implantable device as a primary prevention of mortality?
Essentially, it's based on ejection fraction. If somebody has VT documented, then we call that a secondary prevention device. So this is somebody who presents in VT or has survived a cardiac arrest. What we want to do is, the problem with waiting for VT to declare that this patient's at risk is that, if you have an out-of-hospital cardiac arrest, then survival is no better than 5%. So you're too late in waiting for the event to declare itself to then try and save the patient. If you've got a patient who has heart failure, if their ejection fraction is less than 30 or 35% or less, then they're potentially a candidate for an implantable ICD. They need a full evaluation. There's all sorts of things to take into consideration. So it's not a uniform rule. It's a guideline that we use for patient assessment. But it's based on a couple of studies. In post-infarct patients, there was an extensive study done called MADIT-2 that followed patients out to beyond 8 years and showed a clear, ongoing improvement in survival with an ICD. There was a second study called SCUDHEF that I mentioned earlier, which randomized more than 2,500 patients who had an ejection fraction of 35% or less. About half of them had coronary disease and half non-ischemic cardiomyopathy. And they were randomized to optimal medical therapy, and they all had to be on beta blockers, ACE inhibitors, spironolactone, and aspirin and statins if they had coronary disease. So they were on the best medical treatment they could provide, and that was a third. The other two arms in that study also had the same optimal medical therapy as part of the enrolment for the study, but one group received amiodarone and another group implantable defibrillator. The amiodarone group I've already mentioned had a survival curve that completely overlapped the optimal medical therapy, so there was no improvement in survival with amiodarone. The ICD group had about a 25% improvement in survival over 3 years with the implant of the device. So they were the patients who were getting sudden cardiac arrest that was prevented by the device. So essentially, the ejection fraction is probably the key that we've got to discriminating these patients. One of the problems we've got with it is that it's not an extremely good discriminator, so that you certainly see patients who have an out-of-hospital cardiac arrest whose ejection fraction is better than 35%. And we're still trying to work out what other ways might be useful in discriminating those patients. But for the moment, and this is fully supported because it's randomized control trial evidence from multiple studies, the medical benefits scheme totally supports the implant of primary prevention devices, so they're fully covered by Medicare and private health insurance. And then I mentioned the cardiac resynchronization therapy, same ejection fraction, 35%, but those patients also have to have a left bundle branch block. And if they've got that combination, then they can be considered for a cardiac resynchronization defibrillator. It combines an ICD with the cardiac resynchronization pacing, so pacing left ventricle and right ventricle to resynchronize the ventricle in left bundle branch block. And those patients commonly, as Scott's already mentioned, get a significant improvement in both symptoms and left ventricular function. And in the survival curve, the studies have shown that if they've got a left bundle branch block, they've got improved survival compared with just the ICD by itself, and both of those improve compared to optimal medical therapy.
Some more questions?
What maximum dose of Przemek do you use on this patient?
So we ended up changing him to be metanide, as it turns out, but in this particular patient or in general, he got up to, well, so furosemide equivalence I'm going to talk about. At some stage, we got up to doing the equivalent of, do my maths here, 160, 320 milligrams a day of furosemide in him, which is, I've got a patient in Barcaldine right now who this weekend will be taking the equivalent of 800 milligrams a day of furosemide.
Another question is, did you check the vitamin B12?
Yes, no, with the metformin it's very important to do because metformin can impair B12 absorption. I would routinely check the B12 levels every 6 months for that very reason, absolutely. Yep.
Yeah. Scott, if I could just mention, you made the point before, or somebody made the point before, sorry, about this dichotomy of trying to preserve renal function but treat the heart, and high-dose diuretics sort of come into that equation very much. But in the end, if they've got significant symptoms and heart failure, the cost of treating that can be having to put up with an impairment of renal function.
Yes, it's really important, isn't it, to treat the patient's fluid status, not their creatinine. In the end, the creatinine is a dodgy marker of a muscle protein breakdown getting into your urine, basically, rather than what your heart's actually doing.
Yeah. So if it comes down to the cardiologist versus the renal physician, the cardiologist wins.
No one's ever been... Yes.
Just a quick question about all this advanced technology and being able to have these PA pulmonary artery places. You head back to the doctor, they have a meeting. Who is going to take responsibility for that?
Yeah, so that's what ends up. The whole management at present, management of the PA pressures goes with the heart failure cardiologist involved in the care. So we've got this cohort of patients who, predominantly my heart failure nurse, looks at their results each day. I tend to have a glance at them as well. And if there are problems out of range, she'll get me to recommend an adjustment of therapy. Or with a nurse practitioner we've got, can do it independently. And that works really well. So I'll go, this could be...
Firstly, thank you for this education session. I have a question in regards to BNP as an investigation in heart failure.
Mm-hmm.
I have a few questions actually. Firstly, what's the difference between N-type pro-BNP and BNP? Is one just longer lasting in the blood?
So NT-proBNP and BNP are both, BNP, like number of hormones is produced in inactive form and activated by cleavage of something. The NT-pro bit of that is the bit that's cleaved off and isn't actually active, and has a shorter half-life than the BMP that floats around. Now, in this era of Entresto, which boosts your BMP levels, it won't affect your NT-pro-BMP levels because it's the pre-activated phase. And so if you want to measure the state of someone's heart failure on Entresto, you need to do NT-pro-BMP, because that's an idea of how much BMP is being excreted by the heart in the first place, as opposed to how much has been left in circulation because Entresto is stopping it being broken down.
Great, that was my second question. My third one was, in regards to inpatient management, is there a value in checking serial BMPs to gauge therapy in chronic heart failure, and specifically for gauging improvement for discharge?
That was, has been researched extensively over the years with lots of positive and negative trials, and I guess the most recent one was probably the largest one and suggested probably not enough, or not sufficient benefit to do that. Having said that, I do use BMP monitoring in patients who I can't examine, so I do a large telehealth service, and so I have patients who I'm only seeing via video conference link up. And sometimes I use their BMP when I can't assess them properly as a sort of a gauge, but it's been demonstrated not be effective enough anyway.
You have some comments. So we're using the BNP and pro-BNP for the diagnostic purposes, so if you don't know, and for the prognostic benefit as well, mainly. So the patient would like to have the more prognosis, but I agree that we found not so much helpful in terms of the management for the patient as such. So you might have the patient with clear evidence of decompensating heart failure. I can find the BNP is actually not so much elevated. There is some attempts maybe to use this pre-discharge, again for the prognostic benefit, but you can use for the diagnostic benefit a lot, and actually even suggested that we can use the BNP for the asymptomatic patient, which is very exciting area.
It's good for the patients with preserved ejection fractions who have what looks like heart failure to confirm your suspicion that's heart failure, preserved ejection fraction. I use it a lot for that as well. And I agree with it, that often it's because of discharge things when they come back in with breathlessness and they're a bit ambiguous, you can kind of tell is it worse or better.
That's correct. Yes.
Yeah.
Scott, there's a funding issue for ambulatory patients.
That's right. Yeah, it is. For a particular outpatient, it's an expensive test. It's between, I'm not sure what it is, between $40 and $80 anyway, depending on the lab. There's another question of this.
Yeah, right, thank you.
That's all right.
Thanks for the presentation today. The medical management of this gentleman was exceptional, and we also had a lot of underlying medical problems. But I'd like to go back a few years in this gentleman's history, and as Dr. Kevin pointed out, heart failure can have prognosis similar to cancer. And I think this gentleman needed to be made aware of that. Probably was, but needed to be made aware of that even more strongly than perhaps it was. I think this gentleman could have been encouraged, and we as a medical profession should have looked at that, encouraged to look at lifestyle changes more significantly than he did. There was a few comments you made. He didn't lose weight, he didn't tolerate his medication or take his medication. He really needed to lose weight and he should have been encouraged to do that. He should have been encouraged to use his CPAP device properly and not just, I couldn't tolerate it. I mean, what was that one night he just didn't like it or his wife didn't like it. He really should have been encouraged to tolerate it. He should have been encouraged to cease alcohol consumption. You mentioned something about like Scotch and sort of all laughed at it, but he actually should have been encouraged to not reduce his alcohol consumption, but to actually cease his alcohol consumption. His diabetic management was very poor. I think his last HbA1c was 9.2%. And we as doctors, you know, we manage diabetes, but patients have to manage their diabetes as well. And I just think early on that this gentleman really should have been encouraged to, you know, do what he could have done in terms of lifestyle changes for himself. And it may not have, I think it would have altered the progress of his illness substantially, and may well have given him a better quality of life. And I think it also just brings in where other health professionals can be very useful, and we as GPs, you know, we can start to, you know, we can do a lot of this counselling
I think the multidisciplinary team is very important and early in the piece. Exactly right.
That was the point I just wanted to make. Patient responsibility.
Yeah.
Scott, I was just going to, as a final thing, just ask you about all the different beta blockers around, and your philosophy of which ones to use in what situation. Because I think, I guess two things. One was that, and the other one, there's often a lot of concern when the patient's running a blood pressure of 95 to 100, with all their heart failure medications, which is a relatively common thing, and how you feel about that. Because I think these are common things that crop up in discussing with GPs.
I start with the second question first, because it's more frustrating, I guess. So blood pressure is, once again, a number, and I think it's very important these sick patients to realise that that's all it is. You're treating a patient, not a number. I do not decrease someone's heart failure medications unless they're symptomatically hypotensive. Sometimes, and rarely it is, I do it based upon a rise in creatinine with nothing but low blood pressure as a cause of that. But I have a patient who's in hospital a week with me this week, who we admitted because she was fluid overloaded, spectacularly fluid overloaded, and had been winding back on we had to wind back on heart failure medications. She had a blood pressure of 74 systolic when I saw her, and I stopped her bisoprolol and put her on dopamine infusion to get her some blood pressure to diurese her off, not by a long-term intent to do that. She, at a blood pressure of 74 systolic, that blood pressure has not budged all week, and she has felt the best she's felt for a long time. It's not about and she's mobile and well and diuresing. The blood pressure as a number is of no particular consequence whatsoever to her heart failure. I mean, it's a marker of how bad her heart is, but I didn't need to stop the bisoprolol for her to feel better in terms of that. I just needed to get the volume off as the main message out of that. Now, in terms of choices of beta blockers, I mean, you've got 4 heart failure beta blockers these days. You've got carvedilol, metoprolol XL, bisoprolol, and nebivolol. I have to say I don't tend to use metoprolol XL very often unless they're already on metoprolol, just because the doses are hard to remember and it kind of falls into a grey zone in my head. Carvedilol I regard as being a bit disadvantageous because it's twice daily dosing, but also it does tend to lower the blood pressure a bit, which can be good or bad. So if they've got high blood pressure and you're trying to manage that, carvedilol is the drug of choice for you. It may actually have an impact on diabetic function, have better diabetic outcomes on carvedilol versus the other ones. But I don't usually use that as a big decision-making tool, but I suppose if you're starting someone on beta blocker for the first time, that may play into your thinking. Bisoprolol tends to slow their heart rate down the most, and that's definitely one I would favour in a patient who's got a low blood pressure but a high heart rate. I tend to go there first. And nebivolol I tend to use because it's got data on the elderly, or as a second-line agent when patients have been intolerant to other beta blockers. And I find it probably is better tolerated than the other beta blockers in general, with a similar sort of blood pressure effect profile to bisoprolol, and also some role in HFpEF perhaps.
So if you've got a guy with an elevated blood pressure and a slow pulse rate, which one do you use?
So elevated blood, that's a good one for carvedilol in that sense, and in terms of beta blockers, and that's when you, carvedilol I tend to go with slow heart rate, high blood pressure. And of course, that's when you start using the Entrestos and the nitrates and the hydralazines along the way. With large middle-aged men, spironolactone's a very effective blood pressure lowering agent, and also obviously very good in a heart failure context as well, and I often use that very early in the piece for them.